Hello, everyone, and welcome to the Oregon Rural Health Conference, hosted by the Oregon Office of Rural Health. My name is Rose Locklear. I'm a program manager at the Oregon Office of Rural Health, and I will be the moderator for this session today. First, I'd like to thank our partners, our gold partners, All Care Health and the Oregon Rural Health Association, our silver partners, Eastern Oregon Coordinated Care Organization and the Oregon Association of Hospitals and Health Systems, the River House on the Deschutes, our bronze partner, our QI partners, and copper partners, Westcom, the American College of Education, and Inquisique. Their continued support during these difficult times has made it possible for us to offer the conference to you all at no cost, and we're very grateful to them. You should have received an email with a link to our conference app. You can use this app to visit partners' virtual booths, enter to win prizes, and network with other conference attendees. Next slide, please. Finally, the session evaluation. This is important to complete. It will pop up as a survey after all the sessions have closed out for the day. If you are signing up to receive continuing education credits, you absolutely must complete the evaluation to receive the credits. If you'd like a chance to win a $100 gift card and help us improve, please complete the evaluation. Next slide, please. And the reason we're all here today to hear from Sherilyn Hutchinson about 340B. Sherilyn joins us from University of California, San Francisco Medical Center at Owens Pharmacy. And please join me in welcoming Sherilyn, and she will take it away from here. Thank you.
Hi, everyone. My name is Sherilyn Hutchinson, and as she introduced me, I'm a 340B analyst for UCSF Medical Center. I'm here to talk about 340B, how to make it work for my practice. So I first wanted to start out a little bit about me, so you kind of know where I came from and my background in pharmacy. So I first started out in pharmacy 16 years ago, and I worked 5 years to start at a retail pharmacy. Started at High School Pharmacy, which was a little Pacific Northwest retail store. And I started there as just a pharmacy clerk. And as I got comfortable with that, I realized, okay, yeah, this is something I want to do. I've always had a passion for helping people and for healthcare. I grew up with my mom being a nurse my entire life. And so kind of watching her and seeing that that was something I was interested in some form. And so became a pharmacy technician, became Oregon licensed 15 years ago, then passed the PTCB license, which is the national accreditation for pharmacy technicians 12 years ago. And after I worked in retail pharmacy for 5 years, I really realized a lot of things. I realized that there were a lot of patients that needed help, that there was not any clear-cut way when you're working in retail to help them. I think that was the most frustrating part. It was really hard having patients come up who were on only Social Security benefits and they are getting $1,000 a month and they have to afford food and housing and somehow afford $400 a month in insulin and blood thinners, and not being able to, in retail pharmacy, any tools to help them. So I would just have to say, I'm sorry, and hear, how upset of what they go through and not have any way or any tools to be able to change their situation at all. So after doing that for 5 years, it really wore on me. I realized that retail pharmacy was not where I wanted to be. I wanted to have more power to help the patient, not just dispense things and move them along, and actually work for a place that allowed me and gave me the tools to do that. And so after about 5 years, I went on and I worked at a small hospital here in Oregon, Mid-Columbia Medical Center, and I worked there for 11 years. While I was a technician there, they were so wonderful at supporting me and allowing me to find ways to help patients. I'm kind of growing on educating staff there on the best way to help them from a pharmacy perspective. I did everything from IV ad mixing to purchasing to working oncology prior authorizations. I really did kind of a round scope of the duties there. And while I was there, I was made familiar with a program called 340B. So we had 340B starting in 2010, and I was not familiar necessarily with it, except just basic general dispensing and just slight requirements of 340B, but I didn't have a deep knowledge by any means. Then we were summoned for a HRSA audit, which is the big scary thing when you're a 340B entity. And that's when I kind of got pulled in. Was I loved projects. I loved to be hands-on with things like that. So I got pulled into it. And as soon as I was into it and started looking into 340B, it became very apparent to me that it is something that should not be taken lightly, that there was so much education that I needed to do it justice. I started realizing that everything that I believed in pharmacy of helping patients and kind of closing that gap between rural healthcare and different programs to assist patients all lied in the answer of 340B. So I wanted to make sure that I understood exactly how the program worked and the best ways to navigate it. And that's been through a lot of trial and error. It's definitely been a learning experience. And so I did that and helped manage their program and work with it for almost 4 years of that 11 years I was there. And then that led me to go on and take a position that I was offered with UCSF Medical Center in California, which is one of the largest 340B entities. So it was a huge honor to get them to approach me to offer me a position to be an analyst on their team and their really large dish hospital. And so this last year, I did the final pieces for my 340B education. In 2017, I completed the 340B at Apexis University, which is an online free module through Apexis. And they offer a really nice kind of overview, very simple to follow education. So I received that in 2017. And then in 2019, to kind of further my 340B, I wanted to obtain the 340B ACE certification. So that is offered through Apexis and HRSA. And it basically gives you, they consider you a 340B expert after you receive that. And that's a very comprehensive class. Took me quite a while and I ended up passing it and I learned so much from that program. So we'll talk more about that later, about the value of having somebody complete that within your organization. So I first want to start out with, I want to ask a simple question that I feel that probably at least 95% of you would answer this way is, if I were to ask you why you joined healthcare, I have a feeling the number one response would be to help people. I think that is the number thing that people look at and they say, okay, healthcare, like, yeah, it's where you help people. And whatever form that is, whether it's medically or socially or just helping the whole person, I think that we all can agree that that's why we entered healthcare. So sadly, once we all have been in healthcare, we've learned there's a lot of barriers to accomplishing that goal. It's not always just as easy as saying, yeah, this is the problem and here's how we're going to fulfill that need. There are different things, and I kind of listed some things here on the slide of every year there's more and more Medicare cuts and low insurance reimbursement. Those things directly impact what we can put into services in our community to help patients that need help. High drug costs. I don't think they're ever going down, unfortunately, not on a large scale. And as new treatments come out, those cost even more money. And so I think hospitals and facilities overall see higher drug costs year after year while also having lower reimbursements. Medicare coverage gaps. So a lot of our population that needs help is on Medicare. And as soon as they hit the scary donut hole, there's not a lot you can do for them. And there's a lot of miscommunication where these patients do not know that's going to happen. And they pay a low copay for a while. And then they show up to the pharmacy at, sometimes 5-6 months into the year and have full copays and full prices of the drug without knowing that they were in the donut hole. And there's not a lot to help them after that. And lack of support and tools to help our patients. So all of our facilities, do we have enough support and tools from our organizations that we work with or that we're a part of to allow us to help patients? Another challenge to accomplishing helping people is navigating prior auths and insurance formularies. Every insurance company has a different formulary and what they prefer, and that can be a logistical nightmare trying to figure out which insurance pay for, and it needs a prior auth. Now I have to divert more staff to go through this lengthy prior authorization. It can delay treatment and be a nightmare for clinic staff and for the patient. And kind of my last identifiers was lack of ways to help patients with needs other than healthcare. So we all have seen that sometimes it's not just medically that they have needs. It can be social needs, it can be a lack of food or shelter. All of these directly impact the patient's healthcare. And so it's really important to look at them as an entire patient, which is the last facility I worked at. They were so great about looking at an entire patient and saying, how do we address all of their needs, not just their medical needs? So beyond those other challenges, and also the challenges of rural healthcare. We all know, being in rural healthcare, that there are a lot more things that we have to worry about than sometimes the bigger cities. We have sometimes higher rates of poverty. We have increased travel time to receive healthcare. So if a patient can't get to a place, or the time is increased to drive to somewhere out of town to receive the medical care, they may be more discouraged to going, or going as frequently as they need to. The lack of public transportation, the inability to recruit healthcare providers. It's really hard to get doctors to go commit to moving out to these rural communities. Internet access concerns. As we're in this COVID world right now, we're starting to see an increase in telehealth and video visits and things like that. But when you have your rural locations that internet access is a real concern sometimes, that can be really challenging. And if you throw in a couple of these, of an internet access issue and a transportation issue, where a hospital maybe have set up a place where a patient can go to at their rural place to get internet access, well, if they are lacking transportation as well, now you have a couple challenges in one patient. Limited access to specialists or services, and limited pharmacy access. If you have one little pharmacy that doesn't have access to specialty pharmacy, now you have to navigate to outside of the community pharmacies. That can be a challenge. And lastly, I put less access to charity care programs. So being a rural facility, you are going to not be able to maybe offer as big a charity care programs as some of the counterparts in larger cities. So I'm here to say the exciting part that 340B, I feel, is part of that solution. So every rural community is faced with limited access to some important service or need. We all have some identifier, whether it's any of the ones I listed or any of your own individual ones, that are challenges to be able to help all of your patients and reach them all. I feel that 340B is the part of healthcare that actually allows places to be able to give and reach the patients that are normally unreachable. For hospitals, the drug prices and drug spend increases every year, and I'm sure the same, with clinical as well. So we have drug expense go up, we have reimbursements go down. There has to be something in the middle, and that's where 340B can come in. And 340B is part of the solution to these challenging barriers. Basically what it does is it reduces a facility's drug spend, so you're not spending as much on drugs you normally would without 340B. And in turn, that money saved is intended to be put into program expansion, or a way to use to expand services to your patients that need it most. So the big question is, what is the 340B program? So I wanted to make sure that I include kind of high level. This is exactly what the federal government says the 340B program is. And all throughout, we'll kind of talk about, on layman's terms, what the 340B program really kind of means to all of us. So the 340B program is it's a federal drug program. And what it does is it requires manufacturers who participate and provide the Medicaid drug rebate program. They must also provide covered outpatient drugs to covered entities at the statutorily defined ceiling price. So basically, the cost that they associate with the Medicaid drug rebate program, they also have to extend to eligible covered entities. The purpose of the program is to permit covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Participating covered entities report saving 25 to 50% of the average wholesale price for covered outpatient drugs as a result of 340B discounts. So there are a pretty extensive list of covered entity types, and I kind of want to list those out so we're all familiar with them. And so we have covered entity hospital types. These are the types of hospitals that are able to look to see if they're eligible to be part of the 340B program. And so we have children's hospitals, disproportionate share hospitals, also known as DISH. Those are some of the largest makeup of the 340B program. Freestanding cancer centers, rural referral centers, sole community hospitals, critical access hospitals. And then we have health centers and specialty clinics. So the health centers that qualify are federally qualified health centers, federally qualified health center lookalikes, Native Hawaiian health centers, and tribal urban Indian health centers. And lastly, we have the specialty clinics. So these are the Ryan White HIV/AIDS program grantees, Black lung clinics, comprehensive hemophilia diagnostic treatment centers, Title X family planning clinic, sexually transmitted disease clinic, and the tuberculosis clinics. So first off, basically the foundation of 340B is knowing what 340B eligibility guidelines are. So once your facility, if you're not already participating, once you've gone through and you have seen if you are eligible for the 340B program, and if you go through and get registered, the next piece is to understand this to your very core. The 340B eligibility guidelines is complete foundation of when a patient is 340B or not. One of the biggest mistakes is assuming, being a 340B facility, that every patient is eligible for 340B. They must meet all portions of the patient definition guidelines. It's really misleading in 340B where, and I've ran into this, where I've had a provider who said, well, I looked it up and it just says they have to have a relationship with their facility. And they don't realize that there's all of these other pieces of eligibility that all have to go hand in hand in order for a patient to meet definition of 340B eligible. So it's really important to understand those, make sure your staff understands those, and we'll talk a little bit more about that here in a little bit. But first off, the patient must have an established relationship with the covered entity. Covered entity needs to maintain records of the individual's care, usually through their EHR, the electronic health record. The patient must receive care from a professional employed by the covered entity or under contract or some other type of arrangement. So it has to be a provider, an eligible 340B eligible provider that your facility is under contractual agreements with, basically. For grantees and subgrantees, they must receive health services from the CEA that are consistent with the services for the grant funding. So it has to match what that grant is for. An individual is not considered a patient if the only healthcare service is for the dispensing of a drug for self-administration or administration in the home setting. So it is not enough to just see a patient one time so you can write them a prescription and send them on their way. There has to be an actual proof that there's a relationship with your facility and that you're managing that patient's healthcare. So I wanted to kind of create a visual because this may look very simplistic, but to me, this really sums up the responsibility of being a covered entity. So I call this my 340B umbrella. And from the very top is our covered entity. So that is who is registered with HRSA. It is very, very, very important to understand that your covered entity, you take 100% of the risk. If any error happens, if you have a technology error, you have something that goes wrong at one of the other places or a filter that's incorrect at one of your contract pharmacies, it does not matter. It is all under the covered entity. So the Safeways and the Walgreens and the different pharmacies, they will not have to talk to HRSA and a HRSA audit. That is not their job. It is all under the covered entity. So it's very important to understand that when you grow your program and as you add to your program that you understand the liability that you're taking on. So I just kind of showed that the covered entity, you'll have also your child sites that are registered child sites with your facility. Those can be different types of clinics or hospitals. And then from there, you have your contract pharmacies, but really they all roll up into the covered entity umbrella that takes all the risks. So some of the biggest misconceptions of 340B, and I hear this all the time as I've talked to other facilities, talked to some other hospitals. I have gone out and done outreach with different providers, and I love to ask the question, what's 340B? Do you know what 340B is? And the number one response I get is, oh yeah, it's that drug savings program through the pharmacy, which could not be more incorrect. It's not a pharmacy-run program. Pharmacy is a very big piece of it, but it really is an entire organization program. If you decide to become 340B, it is not something where you appoint a couple people in pharmacy and say, here, have at it. That can be such a detriment to your facility in the future. It's really important to understand from the very beginning and lay such a proper foundation that it is an entire organization. It is everybody from your C-suite to finance, your providers, your nurses. I throw out that even your AAs will help and redirect portions of your 340B. So it's really important in your pharmacy buyers. It's really important to make sure that all of them are educated and that you have a strong support within your whole organization that understands the ramifications of doing 340B incorrectly. I've had times where somebody was getting a free medication through a community benefit program because they met all of the terms of patient definition, and the patient had a glitch at the retail pharmacy, and they called an AA at one of the clinics and said, hey, I was getting this cheaper. And so the administrative assistant directed it to another provider that was not part of 340B because she didn't understand the different ramifications of 340B and how it works. So we may think that not everybody in the organization needs to be aware, but it really helps to have everybody have ownership of this great program. It just helps them to all work together to be compliant. So I find that the sooner an organization understands that, it'll make it way easier in the future. So there's kind of two parts of 340B, and it's important to kind of delineate those because some facilities, or sometimes I've heard people say like, oh yeah, that's the one that brings all the money into the facility, or oh, that's the one where we get cheaper drugs to use in-house. And really there's two different parts. So there is the mixed use outpatient part, and really with that is your using 340B to be able to purchase 340B drugs for outpatients administered within your facility. So you're buying drugs for your outpatients at your different locations that are 340B eligible, and you're saving off the AWP for those patients. And basically that comes across as in drug savings. So that's kind of one part of it. And I went on to explain that covered entities have the ability to add child sites. So if, let's say, and I apologize if a lot of this is directed towards hospitals, that's just what I'm more familiar with. But if you have one hospital that is a 340B covered entity and they have a lot of outside clinics, if those outside clinics meet all of the eligibility to be a 340B child site, then they're allowed to register as child sites on the HRSA database to be eligible with the program. And that gives them access to 340B medications for both clinic administration and for writing prescriptions for patients that are eligible as well. And then so then that leads us to the other piece of you have mixed use and outpatient administered drugs within your facility. And then you have contract pharmacy. So covered entities have the ability to partner with pharmacies that are providing care for your patients to increase access dollars. So this should be a strategic alignment. It should not be, okay, let's add every single pharmacy we can find. That really goes against intent. It's really meant to be a strategic thing where you do research to find out where are your patients going, where are your patients filling prescriptions at, and looking and kind of analyzing, okay, who would make the most sense to partner with, and which pharmacy aligns with 340B intent of the covered entity having the most increased access dollars to expand programs. Adding contract pharmacies increases risks so much. It takes resources to maintain and achieve compliance. It is a completely different ballpark and a lot harder to manage if you don't have the proper tools. Takes a lot of resources for auditing demands. So 340B is a very audit-heavy program. So if you're going to look into adding contract pharmacies for every new one you add, you are increasing the amount of auditing that needs to be completed. So the best thing that I have learned and through all of this is that all third-party administrators are not created equal. So a third-party administrator they are basically, they help run all the filters of your 340B program. So in order to facilitate such a complex program, you need a TPA. Usually your TPA collects dispense data. They take encounter feeds, claims data, and other information from your facility, and they run it all through the filters that you set and manage, and they let you know, okay, what is 340B eligible or not. Without that, it is a very manual process, so it can be done depending on the size of your facility, but most places with a larger 340B program have a third-party administrator. So they assist with determining what patients and drug dispenses are eligible for 340B mixed use, or what patients and prescriptions meet 340B eligibility guidelines. Your TPA houses an auditable database. So if you're ever summoned for a HRSA audit or you're doing your independent audits, your TPA has all of the information within their software that is there to ensure compliance. But the important thing to know is that all TPAs, not one of them, and I've worked with almost all of them now, none of them are plug and play. So the biggest misconception you can make is, well, we're paying this third-party company a lot of money and we're paying them monthly and they say they can do X, Y, and Z. So basically I just plug it all in, we get them up and going, and then they do it all, which could not be that is the most inaccurate thing to think of. No matter what TPA you have, they take a lot of upkeep, a lot of maintenance. You're constantly auditing to make sure you're not having any kind of breakdown, because unfortunately, if anything goes wrong with your TPA, it is the covered entity still your responsibility. So you want to make sure that you're very hands-on and have somebody who's very comfortable with third-party software. So I just kind of did this to kind of talk about how the third-party administrators, so they all come out, they all offer great things. They all come out and they offer different add-ons, and they offer different setups, and they're flexible, but working with different contract pharmacies or different mixed-use setups. Things to look for is make sure they have educated staff. Make sure that you're working and the response people that they're having their help desk, when you call into their help desk, make sure that they've had 340B training. I would ask, okay, has your staff gone through 340B University? It's a free module, it's online, and it is very simple to find out if they're investing in their employees that are going to be working with your company. It's very easy to see if they've had any 340B training. So make sure they have educated staff helping you. Make sure their database is user-friendly. They're usually really good about demoing it and demo multiple times. There is nothing wrong with saying, hey, okay, what are things that I don't understand, and make them show you that their system is superior than another one, or that it meets your facility's needs. Make sure that if you are doing mixed use, that they have crosswalk CDM assistance. So that's kind of a tricky concept, but basically if you're pulling in 5 different NDCs of a type of drug, let's say you carry 5 different types of Tylenol made from 5 different companies, and you are wanting to accumulate that as part of your program, you have to have it mapped of what the NDC is on the inside of the box to what the NDC on the outside of the box is. And when a nurse doesn't scan, which NDC is it going to accumulate? Does that match what NDC you're actually purchasing? So it's very important to make sure that they offer assistance with that, because it can be tricky. And also that they have a really good, strong understanding of the crosswalk. Check if they have flat fee models. So a lot of these TPAs, I've demoed most of them and now worked with a lot of them. And it really varies on what they charge. So it's really important to look and see what are their fees, do they offer monthly fees, flat fees, and kind of analyze that for your facility and your size. Do they offer audit support in an event of a HRSA audit? Do they have a dedicated client manager? Do you have one person you're going to be working with that kind of oversees your program and meets with you to give you any kind of tips or points out any issues? Or are you just calling into a help desk and you talk to random people every time? That makes a big difference. Do they offer things like specialty? Do they offer things like referral capture? That's the new hot topic in 340B. Do they do pending claims? So anything that maybe might be eligible for 340B, but because of one issue did not completely match. Some of them offer a queue where you can go in and double check those against your electronic health record yourself to make sure that you're not missing anything. That can be a really important tool and important offering. So good question to ask for them. And then lastly, do they offer really good reporting and auditing tools? That's really what you want, is your life simplified a little bit as you're doing these audits. Do they have great reporting tools and needs for you? So I just kind of did just a thing on the side of, 3 different TPAs, and these are just, I didn't pick on anybody, but you might see one that says, okay, well, we offer the lowest fee, but then you find out, okay, well, they have minimal reporting and auditing tools. That's not where I'd want to cut the money, because you'll have that then in what you're paying everybody to do the auditing. So, and your staffing resources. So that might not be where you want to cut costs. Number 2, do they have a dashboard of your entire company? If you're a larger facility and you're planning on expanding your contract pharmacy, does their dashboard have something that shows all of it combined so you know the size of your whole program? Sometimes as simple as sounds simple as figuring out, okay, I want to see the whole scope of my 340B program all across. That can actually be a lot trickier than you think. So it's nice if they have a dashboard that has things like that and offers like high-level analytics and crosswalk help. And then, you might have one that offers you referral capture, the CDM mapping, pending claims, but it's a higher monthly fee. But if you're not missing out on any claims because you're capturing all pending claims and anything that that didn't match filtering the first time, but now actually you can go back and prove, well, then that might be worth the extra monthly fee. So just kind of think of those things as you're looking at third-party administrators. So there's a lot of areas to maintain within 340B. And I want people to kind of understand, my biggest thing is, I don't take 340B lightly, and there's a lot of areas that can be really daunting. When I first entered it, I didn't know where to begin, and there's not great resources. I started a Soul Community Hospital. There is nothing really specific for Soul Community Hospitals out there that really just was like, okay, yeah, do this, this, and this. So this is just things that I've learned kind of over the years that I really would love to educate people on, to even know where to begin or what it takes. So these are just some of the ones I threw together, but eligible provider list in your TPAs, or just if you don't have a TPA and you're just managing the program, it's really important to know what doctors are eligible. And that is something that has to be maintained monthly or anytime an eligible provider comes or goes. So if you have a provider that walks out tomorrow, you want to make sure to remove them from any contract pharmacy software, remove them from your mixed use, and any type of part of your program. Otherwise, you could end up with violations. HRSA database. So the HRSA database is where you keep all of your 340B registration, and it has a lot of information in there. It's to keep up with quarterly registrations and annual recertification and maintenance. Anytime a contract pharmacy changes, you have to update that, or if you want to register a new one, or you have a different ship to or bill to address, or you have a different Medicaid billing number. These are all things that have to be maintained within them, and that can actually be a finding with HRSA if the database is incorrect. So Medicaid billing numbers and Medicaid MPIs, you have to maintain those for all states, your facility bills for mixed use. So that can be extensive. Best place to do those is to work with the state Medicaid offices, and they can kind of lead you on what each state needs for billing numbers and MPIs. So if you're doing contract pharmacy, you also have to maintain lists for Medicaid payers. So those are different than the Medicaid billing numbers. Medicaid payers are pharmacy processing numbers, a BIN, PCN group that they use to transmit claims to Medicaid. You have to maintain those, which is not an easy task in itself. Need to know 340B eligible departments or locations and child site maintenance. Grant information in the electronic health book for some CE types if you are eligible because of a grant. Your Medicare cost report. So if you're a sole community hospital or you're a DISH hospital or some of the others, the Medicare cost report is what deems your eligibility. And so to really become familiar with that and work with finance every year to make sure that you have proper eligibility. Drug procurement, inventory, and accumulators, all areas that to watch very closely, make sure that you're meeting 340B eligibility on those. And then also correctable action for any errors found. Unfortunately, you will find errors occasionally, and you have to be able to know how to correct those to meet HRSA's guidelines. So contract pharmacy relationships, sometimes some facilities don't know where to begin, and it is really daunting. It's not a super easy thing to do, but I've learned as I've gone and contracted with a lot of them, kind of what to do and what not to do. Remember, they cannot have access to 340B for your facility without you. So you really are in a bargaining position of talking to them about contracts and looking that over and making sure it's really in the covered entities. It should be in your favor, definitely. So in order to first start out with, if you want to look at seeing who should I contract with, you want to talk to whoever does your electronic prescriptions. They're called a switch. So they can, sometimes they're SureScripts. There's a couple other ones, Relay Health, but they can run you a report, and your IT usually knows where to start. But they can run a report where they look and see where are your prescriptions going to, what pharmacies are they going to. And then from those pharmacies, you should be able to say, oh, okay, well, our cardiology clinic sends most of their prescriptions to this pharmacy. Or, wow, look, 90% of our prescriptions are going to this pharmacy outside of town. We should maybe look at partnering with them. So it's kind of a really good place to start with, is strategically looking. And from there, you can also get reports that show you what drugs are being sent and looking, am I seeing specialty drugs? Am I seeing high dollar drugs? Those are important things to kind of look at as you're looking at expanding. And then what providers and locations are sending prescriptions? Are they 340B eligible? Do I see a lot of benefit there? Remember that your covered entity takes on all risks, costs, and responsibility. So it's important to ensure that the contract is structured to promote the intent of 340B. There's a lot of different, I've seen a lot of different contract pharmacy contracts out there, and all have different models, different fee structures, and I really want people to go into it understanding what those mean. So I'm kind of listing some of the basic ones so those terms are familiar with you as you either review contracts that you have with contract pharmacy or you look at expanding. So first one is the brand name only model. So under this model, only brand name drugs will be accepted. So your prescriptions for your brand name Lantus and Eliquis and things like that will be the only types of prescriptions that go into your 340B program. This keeps claim volume low, so you have less to audit, which is great. But it will also save on true-ups and costs paid to the pharmacy. So it's nice because you will have a lot less prescriptions, but you'll still have a decent amount of increased access dollars and from a brand name only model. The next one is a winners only model. So this basically means that your TPA goes and looks and says, okay, if a claim after paying dispensing fee and admin fees and then paying for 340B cost, you're now at a negative to your covered entity, then we're not even going to use that claim as a 340B claim. This really is one of the best models because no claim goes where you lose. So you don't lose on any of them. You come out positive on all prescriptions. And that also does keep you from auditing because it keeps your volume a little bit lower. Last one is all claims model. This one is not my favorite. I have to say, I'm just putting opinions out there. This includes all drugs, including OTCs and including drugs that aren't even part of the 340B program and supplies. And what happens is you have a lot more claims to audit because now every prescription that meets 340B eligibility, regardless of the drug, will be a 340B considered drug. So you'll pay the admin fees on it, the dispense fees to the contract pharmacy, And if you're not able to replenish it or you don't get a price break on that drug, then you gave them admin fees and dispense fees, even though in return you didn't get anything else. So it's not my favorite model. Do not be afraid to negotiate dispense fees and other fees before signing a contract. Really, it is in your ballpark, and that is something that I have learned. If you reach out to one of the contract pharmacies, they usually will send you a pre-done contract. Do not be afraid to look that over and say, okay, should we be doing this or not? And review how drug replenishment occurs, true-up definitions, and at what point you're given payment. So some of the risks of 340B is, these are some of the findings, that we have duplicate discount, maintaining the HRSA database, diversion, GPO prohibition. These are all really important things to make sure that your facility is trying to make sure does not happen in your program. So you want to make sure that you are following that your database is always correct, that you're not purchasing anything that really is not from a 340B eligible patient. If you're a certain hospital type that's subject to the GPO prohibition, that you're not buying GPO drugs when you shouldn't be for outpatients. And duplicate discount is also making sure that you avoid a manufacturer having to give a Medicaid drug rebate and also give a 340B price at the same time. So there's a lot to avoiding the risks of that. And then this is just a nice big list of types of audits needed. So you should be performing 340B eligibility audits, purchasing audits, Medicaid audits, pharmacy volume, WAC spend if you're subject to the GPO prohibition, grant scope, expired drug audits. You have to account for expired 340B drugs and documenting those, NDC mapping, policy and procedure. Every year you should be having an annual outside audit and an annual self-audit of the entire program. And I really wanted to lastly talk about kind of 340B is to make sure that you're expanding into using all of this saved drug costs and any increased access dollars to help your community. It's the whole purpose. And so with that freed up revenue or money and spend, you should be able to do something to benefit your community in multiple ways. So if things from community health screenings to public wellness program and outreach, expansion of rural health clinics, free or deeply discounted medications to patients that are uninsured or underinsured, transportation to medical appointments, charity care. And I wanted to list some things. I went through and looked at some other hospitals and what they've done, saying from their 340B, and some of them have started medication therapy management clinics. They've started programs to combat opioid abuse, started diabetes clinics, anechoic clinics, hepatitis C treatment programs. So really it's between you and your facility and recognizing in your community how 340B can help. So key takeaways, whether you already have a 340B program or you're considering joining, I am hugely stressed that make sure your key people that are doing it spend the 20 hours and do the Apexis 340B University. It is free. You will learn so much about, okay, all right, now I kind of understand how this works and what steps I need to take. I would make sure everybody does that. Don't jump in all at once. Don't let administration, you don't want to jump in all at once, because the ramifications of not doing it correctly really will just hurt your facility and manufacturer paybacks and failed HRSA audits. So make sure you grow it as you're comfortable, and as you show compliance over the whole program. Okay, now I think we can add a little bit more. Make sure to take it slow steps. Put together a 340B steering committee. You should be having a meeting with C-suite, buyers, IT, compliance, finance, credentialing, and pharmacy that meet monthly to quarterly at the least, to go over how the program's doing, any kinds of potential risks, direction of the program, things like that. Make calculated decisions with program intent. So we have to protect 340B and not abuse it. So it's important to make sure that you're aligning with how the program is intended to be. And meet to decide how are you going to help your community? What demands are you going to meet? What needs are you going to meet for your patients? Educate providers and clinic staff. Ensure you have dedicated staff to handle the demands of 340B. It's definitely important to invest in supporting staff of this program. And have a strong policy procedure. That is your 340B Bible. That is what HRSA looks at in a HRSA audit, as they take your policy and procedure and look to make sure it aligns with what they're actually seeing in everything that's coming through. So here are my references, and I did include, so it's important to look at the 340B PVP tools. That has a lot of great information and kind of self-auditing tools for you to look at. Thank you so much.
Great. Thank you, Sherilyn. We will now go to the question and answer portion of this session.
All right. Thank you so much, Sherilyn. That was a fabulous, formative session. We've got a question coming in the chat box from Brian. He's asking, what advice do you have for covered entities treating 340B eligible Medicaid patients in order to ensure against duplicate discounts when working with the state agency or MCO/CCO, especially when program integrity issues and potential repayment arise?
You know, that's a great question, and that's kind of the topic. So if you're talking about like mixed use, things like that, it's really important to work with your state offices. You know, make sure they're great, especially Oregon is like front runner for Medicaid compliance. They're really hands-on, really approachable, but you know, work with them. I've recently discovered that you're able to reach out to the state and ask every once in a while for you to be able to get everything that they sought a rebate on. So it's important to, I would ask for that, you know, at least annually, and run it against your own mixed use dispenses and see if you have anything there that's missing. And then you have to work with the state on a potential repayment. But, you know, you should be checking with credentialing to make sure all Medicaid billing numbers are accounted for. If you have any states that have approved giving you a Medicaid billing number outside of your own hospitals, so that way you can make sure that they're all covered, and make sure that they're on your Medicaid exclusion file, and that they're also with their registered on the HRSA database. So those would just be kind of pieces. And then contract pharmacy, always have to be reaching out to find out new BIN, PCN, and group numbers for those Medicaid and MCO payers.
Great, thank you. And so you touched on negotiating dispense fees. Do you have any suggestions for that? I think that, you know, negotiating in general can be a little bit of a challenge or a point of friction for some people. So any words of wisdom there?
Yeah, you know, I think it's really important to, if you have a contract pharmacy portfolio, look at the number of claims coming in, look at your bottom line. A lot of times people will just have the checks coming in to one account and then they're paying drugs out of the other to replenish those, and they don't ever match them up. It's really important to match those up to see, okay, do I have a pharmacy that I have 2,000 claims a month and they're a third less than everywhere else? It'll kind of give you, you know, every one of them structures so different fees. That's not really going to, you know, go over well, but it's important to have those looked at. Make sure that if you see any of them that seem like it doesn't make sense compared to the way another one might work, look at things like, what model am I on? What am I paying true ups? Do I have these hidden fees and true up fees coming out? And if so, what can I do to address those? And I would ask for a program review every year and say, you know, hey, this pharmacy is underperforming. If it doesn't meet a certain quota, what can we do to bring that up? Otherwise, we potentially could terminate and go a different direction. So you have kind of those bargaining chips there.
That's really helpful, and kind of brings me to the next question, and I'm sure you can relate to this, having worked at the small critical access hospital. So for some of our communities, they don't really have a lot of pharmacy options locally. And when you're talking about negotiating fees with pharmacies, what sort of suggestions do you have with communities that have perhaps like one pharmacy?
You know, when it's your local, that's kind of what 340B can be a neat tool with, is if you have just a little small privately owned pharmacy, you know, you want to structure it to where you're benefiting them as well, because it's important that they're there as an ally in your patient's healthcare. And so, you know, kind of working out a fair, it would be a lot easier to negotiate with them than it would be some of the big box stores. But kind of like I touched on, it's important to find out where your prescription's going, because if you have one pharmacy in town, they're getting their drugs from somewhere else as well. So it's important to find out from your switch company, where are we having them sent? You know, are they getting sent to specialty, or does their insurance a lot of times mandates where they fill. So find out, okay, where are these going to? Maybe all of this type of insurance makes you go to a Walgreens specialty or an Optum specialty, and look at the percentage. And then, like I said, the types of prescriptions and the providers, see, okay, hey, look, this one I have a good amount. I capture 10 specialty drugs a month, and that could be a big cost savings or increased access dollars for your organization. So it's important to look at those things. It's not all volume, it's also the type of drugs that are being sent out.
Wonderful. Well, thank you so much, Sherilyn. That brings us to the end of the session and almost the top of the hour here. So we're going to close this session out and actually give you all a little bit of time. The next session starts at 1 o'clock, and that's going to be how to talk to patients living with substance abuse disorders with Mr. Jim Winkle, excuse me. So thank you all so much for joining us today, and Sherilyn for sharing her expertise. We thank you so much and look forward to seeing you at 1 o'clock.
Thank you, everyone.